Hello and welcome to a special edition recording in the Alliance for Health Policy's 2020 Signature Series Summit on Disruptors and Transformers. I'm Sarah Dash, President and CEO of the Alliance. For listeners who are new to our programming, welcome. We are a nonpartisan resource for the health policy community dedicated to advancing knowledge and understanding of health policy issues. The goal of this multi-part virtual summit is to explore the short and long-term impacts of the ongoing COVID-19 pandemic and its potential to significantly transform our healthcare system. You can find all of the materials that accompany this recording on your summit interface and on our website. Today, I am so pleased to be joined by Dr. Chris Austin, who is the director of the National Center for Advancing Translational Sciences at the National Institutes of Health. Dr. Austin and his team at the NIH recently launched the National COVID Cohort Collaborative, or N3C for short, a collaborative to study data in real time from people around the country diagnosed with the novel coronavirus. This innovative national research effort is designed to allow clinicians and scientists to determine the best evidence based protocols and treatments for COVID 19 patients as our understanding of this virus continues to emerge. During today's session, Dr. Austin will walk us through the open science initiatives that his team and researchers around the country are working on to advance our understanding and treatment of COVID 19. And then we'll spend a few minutes talking about the role of real world evidence in combating the rapidly evolving COVID 19 pandemic and have a forward looking discussion about how our experience with COVID 19 may transform clinical research in the future. So, Dr. Austin, welcome. It's so great to see you. May I call you Chris?
Great to be here. Thank you, Sarah. And it's great to be able to talk to the audience of the Alliance for Health Policy, because one of the things I'll try to get across is that that about half of what we've done to make these things possible are policy issues. I mean, half of it is technical, but frankly, that's frequently been the easy part. The more difficult part is the policy part, and so I'll talk just a little bit about that. I feel a little embarrassed doing that because I'm talking to the experts here, but you know, we often say at NCATS that half the reason the translational projects fail is because of non-hard science reasons, and one of the reasons they've succeeded here is a tight partnership, close partnership with the science policy community, not only at NIH but elsewhere. So I thought what I would do first as a background is to tell you how we define translation at NCATS. People use this word in different ways. So we have a very holistic definition of turning observations in the lab, the clinic, or community into interventions that are shown to improve health. And those interventions have to reach people in their normal everyday lives in the community in order for us to consider this as a success. So that's translation. And interventions, what I mean is drug devices, behavioral interventions, medical procedures, the whole gamut of modalities. So if you go to the next one, you'll see we have if you click forward, you'll see that our definition of translational research is the process of traversing a particular step of translation for a particular target. And that's different from translational science. If you go to the next one, translational science is a field of investigation. And it's the field of investigation which seeks to understand what the fundamental principles are by which this process happens. It's a remarkable thing that in 2020, most of translation is empirical still. It's trial and error. We really don't understand the general underlying scientific principles or the best practices to make this process more efficient. And when we do understand it, we firmly believe that this whole process of translation, understanding translation, will make the process of developing and deploying cures more predictive, more efficient, and fast. So if you go to the next one, so an illustration of this is the N3C that Sarah talked about. The problem here was that when the COVID crisis began, we did not have anywhere close to real-time, real-world evidence of what was going on with patients in hospitals and medical centers all over the country. And so the idea here was to collect those data from hospitals, health plans, CMS at the peak of the pandemic, and as it evolves into the kind of sequelae that we're seeing. And this required an infrastructure which had never been created before. We had been creating a robust, a high security data enclave for some years to enable this, but we had never had the opportunity to actually test it out until COVID-19. And some of the unusual authorities that are present in a public health emergency allowed us to demonstrate the utility of this enclave. So we stood this up in a total of about 4 weeks to provide this kind of information. So if you go to the next one, what is this exactly? Well, it's a process by which we bring so-called limited data sets, and I think this community knows what I mean by that, into a secure data enclave which exists within the federal system, and all of those data are harmonized so that no matter what the model is that an individual health center or hospital might use, whether it's PCORI or OMOP or Trinetics or ACT or any of the others, we'll just take what they have. We don't tell them what the format is, so we'll take all comers, and then we do the work of harmonizing it into this case in the OMOP standards, and then making both a limited data set in an aggregated way available to researchers. And we're also creating something called synthetic data, which is something we might want to talk about, which has more freedoms associated with it. And you'll notice that if you look at step one, data partnership and governance, that's all science policy. And if you look at collaborative analytics and fair sharing, credit, et cetera, a lot of that is science policy as well. So this was a partnership all along the line. If you go to the next one, you'll see that I'm going to illustrate here what the difference is between this model, which is a centralized model, with other models that you might be familiar with, like PCORI, ACT, OMOP. These are so-called federated models, where it's a question and answer. You have a question, you put out a query to all the different sites, they give you the answer back. Is drug X beneficial to patients Y, of COVID in this case? But what you can't do in this setting is ask the kind of recursive, open-ended questions that scientists and physicians want to know, which is writ large, what drugs help any or all COVID patients, and which actually make them worse? What social determinants of health or comorbid conditions impact the course and outcome? Who ends up on ventilators? Who doesn't? This would have been invaluable information to have at the start of this pandemic. And with this platform, we're able to ask those kinds of questions for the first time. And keep in mind that when we ingest the data, it's not a one-time, it's a recursive, regular update of the data. So if you go to the next one, you'll see that we have spent a lot of time, and you'll have these slides, and a lot of time balancing the need for rapid access to patient data and protecting patient information and privacy. The worst possible thing that could happen is for there to be a breach, for there to be insecurity about the privacy and security of these data. So we've really gone out of our way to make that the highest possible federal rule and standards situation. For data oversight, we have a data use committee that will review all the proposed requests and confirm that the investigator is an appropriate person and has a good reason to access the data. You can't take any of the data from within the platform. You have to analyze it within the platform. You can't download it. You can't remove it. And it's only can be used for research purposes, including, of course, clinical translational research and in public health surveillance. So you go to the next one. When is this going to be open for researchers? Very soon. Because we had done about 3 years of technical work, most of the work to make this possible had to do with the policy, privacy, IRB, data transfer agreements, data use agreements, data access committees, all the things that you're well aware of. But the good news is that as of today, even though we've only been going for about a month, more than 45 institutions have already agreed to transfer their patient data to the N3C. Most of them are hubs of the Clinical and Translational Science Award Program. This is a program which has 60 academic health centers. Most of the well-known academic health centers in the country are part of this platform. Altogether, that platform, the institutions in that platform take care of about 250 million people. So you can see the incredible potential of having all of those data be accessible via this platform. So even though we only have 4 of the institution's data ingested, we already have 18,000 patients. So you can imagine when we have 10 times as many as this, you'll see how many patients we have. So the kinds of questions that you'll be able to ask are in the bottom there. And if you want to see a video that's a little geeky, but it gives you the details, it's at that link there. And again, we expect that this will be available for qualified researchers at the latest by August 1st. So stay tuned. So if you go to the next one, just more quickly, so a couple of other examples where the principle is the same, but the application is different. And the principle is that the best way to make things happen quickly is to share. Share data, share insights, share methods, and when you do that, you take the entire intellectual capacity of the entire country, the entire world, and you put all that to work, working together in as close to real time as possible. Now, from NCAT's point of view, we think that's how the system should always work, and we're hopeful that the precedents which have been established via COVID will be seen to be so much more productive that people will not want to go back to the old ways. But we'll see whether that hope is borne out. So what we're trying to do here is speed the identification of potential drugs for COVID. And so it was obvious from the very beginning when this pandemic came out that one of the best things one could do was to take every drug that had ever been approved for human use by regulatory agencies worldwide, collect them into a collection, and test them across a variety of SARS-CoV-2 assays. That's the virus that causes COVID-19. And we were doing that at our place, and what you're seeing on the right there is a technical diagram of how viruses get into your body and spread. And the point I'm making here is that there's a multi-step process, and each of those stars, we developed testing systems at NCATS, and others did as well, to test, in fact, every drug ever approved for human use worldwide, because we've done this already, and we were ready to go. But the problem is that results and methods have traditionally not been shared quickly. There's publications that have to be done and credit to be assigned, et cetera. And that really limits their impact. So we decided with COVID, even though we've been among the best or even the best in the world at sharing our data, we were going to up the ante here and make these data available essentially immediately, without publications, without worrying about credit, et cetera, because this is a pandemic. There are more important things than publications, believe it or not. So next one. This is another open data portal, a lot like the N3C, but the data here are data from these high throughput COVID-19 tests or assays against all approved drugs, and making all those data immediately available. Go to the next one. So the open data principles, that this should be fast. New data are uploaded as soon as it's quality controlled, so we know it's reliable. It has to be usable by somebody else. We're not obscuring the data. We're not making it difficult to understand. We're thinking of it from the user's point of view, so that you don't have to have any bioinformatics expertise to use this. Any of you on the phone would be able to use this. All the experimental protocols, all the details, all the secret sauce, all there. And you can download, any of the users can download all the results if you want to, and draw your own conclusions, do your own analysis. That's how science ought to work. And that's what we're doing here. Next one. So what's coming next? We're currently working on drug combination data. You're probably aware that in a lot of infections, it takes more than one drug to work. Taking high content pictures, these are microscopic pictures that we often generate in these kinds of screens, incorporating animal model data. And this is a screenshot of what it looks like like they're the red and green are ones that these are compounds along the top there, and their assays along the side, and to looking at what compounds worked in what assays and increased or decreased activity. That's the red or the green. And then the black ones are when they didn't do anything. And one of the most exciting things about this is that 6 other research groups who we've contacted have expressed willingness, and they're currently doing, to also deposit their data, because they have realized as well that open data is the way to go. Not everybody, but it's a start. So check back regularly to see what we've done. Last one I want to give you a tour through is something called Cure ID. If you go to the next slide, this is actually an app, a mobile app that we created with the FDA that debuted the first week in December last year. It's well timed. And the idea here was to allow healthcare workers to contribute their own knowledge and experience treating infectious diseases all over the world with approved drugs, and to share clinical cases and treatment questions. We could not have done this at a more propitious time, because 3 weeks later, the first COVID case was diagnosed. So if you go to the next one, you'll see what the homepage looks like. You see in the upper left there is COVID-19. We put it up there because we figured a lot of people would be interested in that. But if you're interested in acute necrotizing encephalopathy or actinomycosis, you can also look on those as well. If you go to the next one, you'll see that this is crowdsourced data from real clinicians all over the world who are using compounds that we don't yet have clinical data, robust controlled clinical trials on. But this, again, just like the N3C and just like the data portal, are going to give us real world evidence of what's working and what isn't. These are groups of anecdotes, of course, so they're hypothesis generating. But you'll notice a few things that you probably recognize here: hydroxychloroquine, zithromycin, interferon, methylprednisolone, which is like dexamethasone. So if you go to the next one, I think that's it. Oh, so the Critical Path Institute, I think you're all aware of, collaboration between the FDA and the Critical Path Institute that's been going on for some years. They were so excited about this that they have jumped into the collaboration as well to expand this, the access and the resources that are available, so that more clinicians will be able to report more novel uses in a more facile way. So this is now a 3-way collaboration between Critical Path and the FDA and ourselves. So this is another thing that we're seeing in the COVID situation. Organizations that traditionally have thought of themselves as pretty separate, they're not separate. They've never been separate. They're at least adjacent or overlapping, but they've tended to separate rather than work together. And we're seeing exactly the opposite in this case. So I think that's it. That's the next. I think the next one is just an advertisement. Yeah. Sarah, I'm eager to hear your questions.
Great. Well, thank you, Chris. Well, you actually left off on a great note about collaboration, and I see that the very first point under NCATS is collaborate. So let's just launch in and talk about that for a second. So you talked about this unprecedented collaboration. We've heard that from the research community elsewhere. That's really has ramped up their efforts to look for cures. That and therapies and treatments has done this in an unprecedented way. Talk a little bit about, what were some of the barriers to this collaboration kind of pre-COVID, and kind of what were the barriers you had to overcome, to get something like this up and running in just 4 weeks, and what did you build on to do that?
Yeah, so it's a great question, and the implication of your last question is really important here. If we had not had this attitude, if you will, long before this, we would not have been able to capitalize on everything that we had been building that made this possible. So for the last 3 years, I mentioned that we had been creating as close to a bulletproof data enclave into which such data could be put as possible. And so because we knew that without that ironclad privacy. We couldn't, in good conscience, ask any academic or other hospital institution to give any kind of data to this collaborative effort. So that was the first thing, to be able to convince our partners that we'd done our homework. The second was that we had funded something called the Clinical Data to Health programs. It's an informatics program that's part of the CTSA program. Sorry for all the acronyms, but as you know, NIH loves acronyms. The Clinical Data to Health program is just what it sounds like. It's a large collaboration of 13, 14 institutions all over the world, all over the country, part of the CTSA program, that are asking, well, what are the common problems and common opportunities across the network, and working with all 60 of these hubs to start to put that infrastructure in place. And so when COVID happened, the CD2H group said, okay, this is our moment to shine. And we'd also done something called Smart IRB, you're probably aware of, a nationwide IRB reliance agreement, which had created a trusting relationship among now over 700 institutions all over the country that had signed a treaty, if you will, to rely on each other for IRB purposes. So we were building on all of that history, a trust, and that's really what this comes down to. And so what we then needed to do was figure out, well, gosh, what kind of data that we can get that has to have some identifiability to be useful. What kind of data can we get without running afoul of HIPAA and other regulations? And it turns out that this limited data set that actually has only two criteria that are thought of as or considered protected information. That is date of service and zip code. So those things are absolutely essential if you're going to track a pandemic. Those are the only two things, in addition to what their characteristics are, clinical characteristics, are that we get on the patients. We don't get any other identifiable information. And the only information we get is on patients that have COVID or have COVID-like symptoms. And so not all the patients we have COVID. They might have flu, they might have MERS, they might have SARS, some other disorder. And so we had to do a lot of work with our colleagues at these institutions to get everybody comfortable with the idea that this limited data set was appropriate to share, particularly under a public health exemption. And then we had to deal with multiple IRB issues because this was new. This was new for the institutions, and we had to get them comfortable with all of this. And that takes some time. But because we had built these trusting relationships, that was the only reason it was possible. We were talking about, before we started on the official part of this program, we were talking about how many people we're talking about here. There are over 100 institutions, academic institutions, hospitals, nonprofits that are involved in this program, and we are all working together. Over 500 people have contributed to this program. And the only reason it's worked is it is a massive, very diverse group of people, some of whom have technical expertise, some of whom have policy expertise, some of whom have clinical expertise, and they're all working together in one big scrum. It's like a giant rugby scrum, the world's biggest rugby scrum. And I got to tell you, it is so gratifying
That's
for the
great.
people working on this. This is what scientists want to do important things.
And illustrate for us, just I love it. It's a very organized rugby scrum though, right? Like you put it all
Oh yeah,
together. Who are some, like, what, these are researchers across the country, you
yeah,
mentioned, in academic medical
yeah,
centers, like
yeah.
what kinds of researchers get access to these data? Is it people
Right.
who already have funding, or can anyone
Yeah.
just kind of come up with a question? Like, how is that part organized?
Yeah, so it's a great question. So the CD2H group is run out of Oregon Health Sciences University. Investigator named Melissa Handel is the PI for that. But there are people at multiple other institutions, at the Jackson Labs, John Wilbanks, who I know you know, at other nonprofits. So these are folks who who come from many different institutions, which are they're all funded by us. That's the other reason that they come together. I don't want to minimize that. It's not just goodwill; it's that we pay them. But that's fine. That's appropriate. Um, an important part of this program, though, that you touched on, which is that you don't have to be a depositor of data to be a user of the data. Sometimes these things are created a little bit like country clubs, and it's a pay to play or contribute to play. And frequently the people who have the questions, the most important questions, are not the informatics or policy wonks that we all are, who can put these platforms in place in the first place. So it's very important to make sure that any qualified researcher, and that's a term of art that applies to investigators who have a good research reason, and they come from a research institution generally or a policy shop, they have a good reason to want access to the data. Anybody who fits those characteristics, and that's been quite well worked up through things like dbGaP and other public resources, they can have access. That has to go. They have to sign a data use agreement, and the application has to go through a data access committee to agree that the person is asking a worthwhile question, et cetera. The other thing that's important, they have to tell everybody what the outcome is. They can't keep it secret. They have to tell everybody what the answer is, because remember, you can't take data out of the enclave. So we can track everything that everybody does within the enclave. And what that means is that when the smart person comes in and asks an important question, they can't keep it to themselves. They have to share it with the whole community. So it's everyone has to buy into this open access, and we've made it as hard as possible, we hope, for people to take advantage, because some people will do that, and then it ruins the whole thing for everybody.
Right. Well, so let's just talk for a second about the kinds of questions that we're trying to answer here. And
Yeah,
I think a lot of people who are kind of worried about this pandemic, which is probably everybody right now, and wondering, what kinds of cures or therapies might be available. They may
yeah,
not be as focused on the research
yep,
infrastructure, but
yeah,
talk a little bit more. You mentioned a couple of the questions. What are some of the new things that we're learning that you think that this is going to enable us to learn about COVID, and how is
yeah.
that going to then help patients?
Yeah, yeah. Well, the first thing, and this is evolving, as you point out, is that when this pandemic happened, uh, everyone felt an imperative. Everyone, what I'm talking about here is people, doctors taking care of real patients in real hospitals, did not have the luxury of having any data, any previous experience with the course of this illness, what happened to people, why did certain people end up in the ICU and other ones didn't, why did people do well, certain people do well, and certain people have no symptoms at all. People were using hydroxychloroquine and azithromycin and 100 other drugs off label, using their clinical judgment, which they're entitled to do, and they should do in the absence of data. But just imagine, this was a grand experiment going on in hundreds, thousands of institutions all over the country. And if we had been able to capture that real life experience in real time, we could have answered, does hydroxychloroquine work or not? Does it work for outpatients? Does it work for inpatients? Does it work for people who are just a little bit sick and prevent them from getting on a ventilator? Does it help when people are on a ventilator to die, prevent them from dying? The same thing with all the other treatments that were being used in the field. This issue, which has become so painfully aware to all of us now, evident to all of us now, that underrepresented minorities are way overrepresented in both cases and deaths in most parts of the country. We didn't know that because we had no demographics countrywide on who was being affected and who got sick and who didn't. If we had had this database, this data platform, we would have been able to answer that question in close to real time, and we would have known it and be able to intervene. Same thing with the elderly. You probably remember there were places that were intentionally sending the elderly to nursing homes to protect them
Mhm.
because they thought that was the place to put it, and there was no data to tell them that wasn't the right thing to do. So all of those are things which we would have been able to answer. Now the $64,000 question now is, why the heck are we seeing this dramatic increase in cases now? Why is it in a different demographic, which to a great degree it is? It's a younger demographic. The kinds of symptoms we're seeing are different. We're still seeing this awful multi-inflammatory disease of children, which you may have heard about. But we're seeing it in younger and younger people, and teenagers, 20s and 30s. The death rate is generally lower. But why are some of those people getting sick and other ones are not? There's also, you may be aware that actually the so-called sequence of this virus, the RNA, the guts, the instruction book of this virus has changed in very significant ways over the last 3 months. And the current virus, which is circulating, appears to be about 10 times as infectious as the virus that we started with back in March.
Hmm.
So how does that relate to who gets it and who doesn't? Doesn't seem to be more lethal, but it is more
Right.
infectious. So those are
And
all the kinds of questions that you'd be able to ask.
yeah, and how does this kind of intersect with some of the other data efforts we're talking about, public health surveillance,
Yeah,
data, there's public sector and other private sector efforts around,
yeah,
just public health data surveillance,
yeah,
symptom surveillance, like even genetic research is happening. People, as you mentioned, kind of looking at the DNA, the RNA, like the different
yeah.
mutations. How does this all kind of fit together?
Yeah, so as you might imagine, uh, our our goal is to have all of it fit together. Currently, it doesn't. We just haven't had long enough to do it. But what I can tell you is that we started out with inpatient data, so about 80 to 90% of the information that's in the N3C now comes from hospitalized patients. So that eliminates a large number of people who were asymptomatic or marginally symptomatic, are not inpatients, because they won't be in an electronic health record. But for the most part, some do. Um, However, anything that is any lab tests, including a sequence, that are in their medical record will be captured. So we would be able to capture if their data are, if their virus is sequenced, and we can see that the sequence is different in different parts of the country, we'd be able to see that. Um, the we've connected as much as we can with the other resources that you're mentioning, for a very simple reason. The CTSA program is not simply 60 academic health centers, the well-known names that we all know and sometimes love. Those big centers are the so-called hubs. But the important thing is that each of those hubs has about 10 spokes to community health departments, federally qualified health centers, practice-based research networks, and all of those data tend to be captured in the EHR of the hub. So, and that's one of the incredible advantages of this national resource we call the CTSA program. It really is an incredible national resource because it is so connected, and we can get all of these data all at once, not only from the tertiary care centers, which is, it's a specialized group, but from secondary care, primary care, community-based practices.
Great, thanks. And you mentioned earlier real world evidence, and
Yeah.
it sounds like you're trying to get as real world and real time as possible. So say a little bit more about that. Why is that so important in this kind of developing emergency?
Yeah.
Are there limitations? What kinds of kinks still need to be worked out?
And this is always important in the case of medical care and science, because of course the fields always advance and they change over time. But this is an extreme case. I have never in my career, I don't think any of us have seen anything like this on this scale and rapidity of change. We're literally from a day to day, from one day to the next. What we think we know has changed. And so what it requires is to have an ability to go back to these sources over and over and over and over again, weekly. We're hoping twice a week eventually to ask these same questions so that one doesn't have a moment in time. One has a longitudinal view of what's happened in a community and those characteristics, how they've changed over time. That is requires, like most things in life, to make something really easy and facile is really hard. And but we have worked really hard to do that because it is really important that we, the experts, the policy experts and the technical experts, make it as easy for the people on the front lines as possible to deliver their data. And this kind of centralized model allows you to do that. So from a maybe slightly technical for a second, what this requires is a transfer of data from an institution. In order to do that the first time, you have to set up all kinds of characteristics of what you want to do. And in a federated model, which are great, I don't want to minimize that, but something like the Corey or Act, you have to do that every time. You have to set up a different question every time, and you start from the beginning every single time. Here, we do it once, and all we got to do is say, okay, transfer again, push the button. So it's very easy for the system to ingest this new data. The other thing that's really important is that these kind of data, this kind of data enclave and this collection of data allows you to ask questions and get answers that you had no idea you should be asking, right? So federated questions are great if you know what the question is. You know, is your name Sarah Dash? Yes or no? However, if I have no idea what your name is, I have no idea what the question is. So by analogy, if I don't know what drugs work, I have to guess. And I just have to keep guessing and guessing and guessing. Whereas here, because all the data are in a single enclave, you can use some of the magic words that we hear all the time, things like machine learning and artificial intelligence, to say, okay, Mr. Computer, Miss Computer, uh, what drugs work the best? In what patients? Are they African American? Are they Hispanic? They're white? Are they young? Are they old? Which ones work in which people? Give us the whole 9 yards, and you can ask it once.
And you can ask them. And as I understand it, we're learning, so much every day. I know you trained in neurology as well. This is maybe not just respiratory illness. We're seeing these
Oh,
strange
yeah,
neurological symptoms. We're seeing blood clots,
yep,
things we never anticipated at the beginning. So it
yep.
sounds like you can kind of get at some of those as well.
Yeah, this is a really important point because this is it is very clear that this is a really nasty virus. It does infect the lungs like any pneumonia does, but it also infects blood vessels themselves, infects the blood vessels. And if you infect a blood vessel, it causes inflammation, and they form clots, and people get strokes and heart attacks, etc. I just read a paper today that shows that in a large study in Europe, almost 50% of the people who had recovered from COVID had uh, detectable significant heart abnormalities by echocardiogram. 50% of the people had heart damage that was lasting after the infection went away. That is something that we have not seen since the likes of polio
Mm.
and syphilis and other disorders that result in permanent damage. It's not like the cold. It's not even like the flu.
Yeah.
And so these so-called sequelae, that's the technical medical term, uh, we're going to be able to follow those because remember, these people are going to be coming back to the hospital.
Mhm.
And so we're going to be able to say, well, okay, a month from now, what's going on with these people? Do they have kidney trouble? Do they have heart trouble? Do they have brain problems? Do they have nerve problems? Do they have liver problems? And we don't have to know what the right answer is. And
Right.
that is just magical. It comes
Mhm.
as close to when I was a kid, I was a Star Trek fan. It was as close as the tricorder as I've ever seen. Um,
Yeah.
so, so I hope you can excuse my enthusiasm here, but it really is something that I've dreamed of as a clinician my whole career.
Well, that's great. And if I could ask you just a kind of a couple more questions as
Yeah,
we kind of
sure.
wrap up, and obviously answers to all those questions are going to then have important policy implications as
Yep.
well, of course, as we
Yep.
think about the kinds of care that people need who are
Yeah.
survivors.
Yeah.
um, t- you mentioned something about the open data portal, I believe, making something more user friendly. We know what kind of just unbelievable stress our clinicians are under right now, who are taking care of
Yeah.
COVID patients, our nurses, our physicians, in terms of data entry. How does this make it easier for the clinical community to submit, or does it kind of relieve some burdens on
Hmm.
data submission compared to other efforts? Do you have any
Hmm.
comment on that?
Yeah, so N3C, the open data portal is something where people actually do have to deposit their screening data from, and these are lab-based screens of large, thousands of potential drugs against in a lab against the virus. Uh, and those, of course, do require people to submit their own data. One of the beauties, well, and Cure ID too, but both of them are designed to be as easy as possible. And part of the secret here is that I don't want to hit on my, probably get in trouble by saying this because some of my informatics colleagues may complain, but the fact is that many databases are very hard to use because they're made not for the user, not for the depositor, but for the informatics person. That's just
Mhm.
what human organizations do. And at NCATS, we have both users and generators of the data, and we have the informatics people. So it is impossible for somebody to put out a database or a data platform that is hard for users to use, because our users will call our informatics people to task and say, I can't use that. That's no good. And that's an unusual circumstance.
Mm.
It's something that, part of our DNA, if you will, is community engagement, finding out what the people are who we hope to use the data. What do they need? So in the example of clinicians in N3C, the whole word deposit is rendered irrelevant or archaic. That is, nobody has to deposit anything because it's already in the EHR. The only thing that has to happen is for the people at the institution to write a script, a macro essentially, to transfer those data into this secure enclave. But the clinician doesn't do that. It's the head of informatics at whatever the company is, or the hospital is. So it's transferred automatic. Now I must say that from a policy point of view, that can be a little scary, right? Because there, what that means is that people need to be assured that, well, gosh, you're not going to just transfer data willy-nilly. How are we going to know what you're actually transferring? How can we trust this? And that's why the whole aspect of data provenance and having a blockchain like uh, archive of who does what in the system and where the data come from is so very important. And I must say that we have changed a number of the procedures we use to ingest and analyze and combine data
Mhm.
in response to our science policy colleagues who said, look, this is either going to be more legal or more acceptable, will keep you out of trouble, will lead to greater sense of trust. And so we've made those changes in a very collaborative way.
Great. And one last quick question before I get to sort of like the closing is, do you have any hopes of getting patient generated data at some point? People who are out in the community kind of
Yeah.
coping with this in whatever way that they're coping with it, whether asymptomatic or mildly or worse.
Yeah, there's a large effort, several large other efforts, and you may want to have some of my colleagues on to talk about this. There's a very large effort in diagnostics, which is going on, run by my colleague Bruce Tromberg, who runs the bioinformatics, or the Bioengineering Institute. There's a large effort in looking at antibody testing, serology, looking at people who have people been infected or not, and how can we give people confidence that they can return to school or work. That's being run by the National Cancer Institute. Ned Sharpless, who's the director there, could talk about that. And there are other efforts to gather data, and we're involved in these, but it's separate from N3C, gather data from clinical trials that are ongoing to say, well, could we share clinical trial data? And we're doing this in a large collaboration called Active, as you probably heard of. It's a large public-private partnership with a large number of pharmaceutical companies, ourselves, and other parts of the NIH and the federal government, to share clinical trial data. And a number of those are oriented to people who are either asymptomatic or marginally symptomatic, people who need to get tested in the community, which tests work and which tests don't, and which ones can we rely on and which ones we can't. Something that's going to become increasingly important as we all think, well, gosh, we'd love all of our kids to be able to go back to school and have the sort of social interactions that we know are so essential to development and learning. This is a critical issue. It's not a nice to have, it's a need to have. But at the same time, how do we do it with protecting the students and the teachers? And so those are separate projects at the NIH from what we've talked about today.
Great. Well, so many important efforts are needed, and it's clear that this, unfortunately, this pandemic is going to be with us for a long
Yes.
time, and it's not going away. So, as you think about, just in closing, you know, sort of the unprecedented nature of the collaboration of some of these platforms, the N3C, others,
Yeah.
how do you see that this use kind of moving forward beyond COVID-19? Do you think there are lessons learned now that we'll be applying in the future? Do you think this is
Yeah.
going to fundamentally change the way that research gets conducted down the road?
I hope so. I hope so. And what I mean by that is that there's some discrete things. Just to mention one, telemedicine. Having sick people have to travel sometimes 2 hours to go to a major medical center to be seen has not been really necessary for many medical purposes for many years. It just hasn't happened. Now it's happening all the time because we don't want people in major medical centers.
Mhm.
So that's a major change. Would have to do with reimbursement and coding and all these things. So we're hoping that those kinds of things will change. The biggest thing that I hope changes is is the sense of urgency that the public has about health problems, diseases. I deal every single day with patients and parents of children with lethal diseases, many times rare diseases, but common ones too. And their question is often, why does nobody appreciate that time is not on our side? We can't waste time. We don't have time to have people delay 2 years to publish a paper. We've got to infuse a sense of urgency into the system. And for the first time in my career, I am seeing that. And you ask yourself, why? It's because for the first time, again, in my lifetime, every single person on the planet is worried about getting and dying from a very bad disease. So every patient now is like the medulloblastoma child patient or the ALS patient, where they don't have time and they're scared. And that realization that there are 7,000 diseases out there affecting millions of their fellow their fellow members of the United States and the world who deal with these problems every day. And gosh, don't we have a scientific, a medical, and yes, a moral obligation, ethical obligation to change the way we do business, to demonstrate, to deliver on the kind of rapid progress for every other disease that we've seen happen in COVID, and to maintain the kind of collaborative structure, the sharing of practices that have made that happen. So I've gotten to saying that, like you, Sarah, I've been arguing for a lot of these changes for decades, and we've known that people can do these things. They can share. They can choose to share. This is not a can't; it's a won't. And we've now seen people who said, "Well, no, I can't share." They're sharing, and progress is much faster than it ever was before. And so the genie is out of the bottle. Genie's out of the bottle. So the question for me, for us, I think for all of us who work in this business is to figure out how to get the cork in the bottle before the genie gets back in. So and that's I would just leave you with that to think about this from a technical point of view, from a policy point of view. What can we do to make that happen? Um, and I think if that happens, there will be an enormous silver lining to this very terrible pandemic that we're living
Well, that is, just a positive note to end on.
through.
This
Yeah,
is obviously such a human tragedy on so many levels, but perhaps it is possible to make progress now for the people who need it, and down the road in the future,
yeah,
accelerating science, accelerating treatments and cures
yeah,
that we all so desperately need.
yeah.
Um, Dr. Chris Austin, thank you so
Thank
much for
you.
joining us. It's been
Thank
an
you.
enlightening hour. We really appreciate it, and you've been so generous with your time. We look forward to
Thank
seeing the results, and to staying in touch on that.
you. Very,
And
very good.
thank you. And for our audience, again, you can find recordings of previous sessions for our summit, and additional resources on our website. And again, Chris, thank you again, and we will be in touch.
Great to be with you. Stay in touch.
All right,
Take care.
take care.
Bye, Sarah.
Bye.